Hi, I'm Joanne Kenen. I'm the executive editor of healthcare at POLITICO, and I will introduce our panelists. We've got, my list doesn't correspond with their order, but I'm just going to go with it. Georges Benjamin, executive director of Public Health Association. Thomas Moriarty, executive vice president, chief policy and external affairs officer, and a couple other things at CVS. Ashley Perry, senior vice president at Socially Determined, and we will explain what that is. Lauren Shweder Biel, executive director of DC Greens, which she's going to make sure you all eat a healthy lunch. And Emily Yu, executive director of Build Health Challenges at the Beaumont Foundation. I really like panels on social determinants, because it's not something that we talk about once and forget about. It has really changed how people think about healthcare, and I think it has changed it in a lasting way, and increasingly it's changed it in a bipartisan way. But the question is, how do we define it? Do we have a common definition? What is the responsibility of the healthcare system? When do you spend the healthcare dollar? And when do you light a fire and work with somebody else to spend their dollar in a way that benefits whatever needs you're trying to address? So we're going to talk a little bit about the business case for so. I think probably everybody's in this room because they understand the common sense and they understand the moral case, or you probably would be at a different session. But how do you make it work? And how do you, if you make it too broad, you're gonna destroy it, right? And then people are gonna look at your, those state Medicaid budgets and say, you don't need this money, you're spending it on everything else. If you spend it smartly, we'll have a better healthcare system and a happier and healthier population. So I think that's gonna be what we spend the next hour talking about. And I want just to get everybody, because we don't have a common definition, I think everybody would include housing. I don't think anybody is going to talk about social determinants without talking about housing, which is probably the most expensive problem. But I just wanted to go down the row and have everybody just say one or two things they also think of when they hear social determinants or social drivers or whatever other name you're going to start. So start with you, Lauren.
Great.
No speeches, just 2 or 3 words.
Well, I mean, just to say, I run a food justice and health equity organization here in DC. So for me, when I think of social determinants, it's very much focused on food as medicine and food security.
Georges.
Yeah, I mean, lots of things, but transportation and income inequality are two.
Right. Tom.
We think about it, all the things that happen outside of the doctor's office that can influence your ability to meet what your doctor wants you to do.
At Socially Determined, we think about the significant 7, we call it. So economic strain, food insecurity, housing instability, transportation barriers, health literacy, crime and violence, and social support.
Very well said in a brief period of time. And Emily.
Foundations of health, where you work, live, and play.
Okay. So I always tell my panelists that they should get engaged with each other, and if I snuck away, they would keep talking. So I'm just going to get them going. We do have a change in how we think about health, and I've heard it from conservative Republicans in southern states. I have not interviewed every conservative Republican in every southern states, but it's not just. It has evolved, and people talk about it in terms of ROI, not just do-gooding. So how do we take advantage of this moment? And as you were all figuring out how to prioritize. We're spending trillions of dollars on healthcare, and we all know we waste a ton of it. So when you want to take that dollar and address the social determinants, where do you start? Maybe we should start with the local organization here in DC, which is finite. You're dealing with food. But how do you build out? It's way bigger than giving somebody a carrot.
Absolutely. DC Greens, one of the things that we do is run a produce prescription program here in DC. For those of you who aren't from DC, we're focused in Ward 8, which is a part of the city that is multi-generational poverty, about 100% African American. The health disparities are dramatic. There's a 17-year life expectancy difference between Ward 8 and where we are right now in the city. And 4 of the top 5 leading causes of death are diet-related chronic illnesses. You also see diabetes rates 5 times higher in Ward 8 than here. And there's also one full-service grocery store for 85,000 people. Compare that to a grocery store per 10,000 people in this part of town. So what we've been doing here is partnering with AmeriHealth Caritas, which is DC's largest Medicaid provider, DC Health, which is our health department, Giant Food, which is that one full-service grocery store, and health clinics, federally qualified health centers around, in Ward 8. And they are the clinicians are writing prescriptions for AmeriHealth patients that are diabetic, pre-diabetic, or have hypertension. The prescription is called into the Giant pharmacy. The patients go to the pharmacy. They receive a $20 coupon to spend in the produce aisle at Giant every week. Giant has also hired an in-store nutritionist, so there's basically a warm handoff to a nutritionist who does personalized store tours, free nutrition consultations, and the patient goes back to their clinician every 3 months to get a new prescription. Amazing from a sort of a social justice perspective. What has been the most amazing for us is that we've actually been able to bring in Socially Determined. Ashley's here from Socially Determined. And there's a data use agreement now with AmeriHealth Caritas. And so this is one of the first interventions like this in the country where we've been able to actually access the claims data and do a large-scale evaluation of the impact of the program on patient utilization of the healthcare system. So things like ER diversion, medication compliance. I mean, I think we all know, in our hearts that, these types of interventions are good, that they help, but I think, we are now finally on the cusp as a food as medicine sector, which includes things like medically tailored home delivered meals, food pharmacies, produce prescription programs, of actually trying to prove out that business case. Because I think we know that the only way to actually create a sustainable funding stream for this and really integrate food as medicine into the healthcare system is by really speaking the vernacular of the healthcare system and being able to prove out that core business case to the healthcare system.
And are the people who get the prescriptions, is it just if you were a Medicaid patient, or is it if you're a Medicaid patient with pre-diabetes or diabetes? I mean, is it
Sure.
everybody who qualifies Medicaid, or is it targeted?
Yeah. So right now, we have funding for 650 patients. We've gotten, now the Dell Foundation has come on board, the Rockefeller Foundation, there's become a lot of interest in this, so we are hoping to continue to grow that patient population. But currently, it is AmeriHealth patients living in Ward 8 who screen positive for diabetes, prediabetes, or hypertension, which is quite a large percentage of that population. We are working to bring the other MCOs in the district on board as well.
Medicaid managed care.
Yes, the managed care organizations. But from my perspective, I really want to make sure that there is a data use agreement in place with Socially Determined for anyone that comes on board, because I think in order for us actually to shift the system and actually, push us over this tipping point, we know that we need to be able to prove out with strong data, and we're very grateful to have Socially Determined as I call them they're sort of a skeleton key in being able to actually access this kind of claims data and do the type of analysis that is needed for folks working like I am in the sector.
So Ashley, in Socially Determined, you're looking at a number of projects in a number of cities. On one hand, this is an exciting thing to hear what they're doing and that they're getting data and you're helping her with that data and analytics. It's also, if you're going to be skeptical, it's 650 people getting fresh fruits and vegetables in how do you spread it? How do you build it? How do you healthcare is really lousy at spread, right? Yeah. You go to a conference and you see the same person talking about the same thing year after year. How do you make not a million of her, but how do you make a lot of her?
Yes. So that at Socially Determined is what gets us really excited about analytics, because it allows us to scale pilots that are often funded through philanthropic efforts into sustainable business solutions that are core to our partners' business strategies, right? And so we think about that a lot. AmeriHealth partnering with DC Greens on this initiative, our ability to quantify the impact that that's having on the key business metrics that matter to AmeriHealth will drive scaling of the program, not only here in the district, but in other markets as well. And so our ability to look at populations that either health systems have taken on risk for, or that payers are inherently at risk for, or that employers are at risk for, and be able to quantify today what is the correlation between elevated social risk and excess utilization and cost, or poor outcomes, that is costing your organization money today? And then how do you think about deploying those same resources more effectively in interventions like Produce RX that are going to, number one, save you money, and number two, improve the health of the populations and communities that you're serving? That's where analytics and scalability come together.
George, when you look at this as a national perspective, when you hear about something promising, interesting, but in one neighborhood where there is transportation, there is, some of it's walkable. I mean, compared to...
A lot of it's walkable, not a lot of buses over there.
Right, well, I was just in North Carolina.
But I got it.
I'm
All right, by comparison.
I have been to Ward 8, and compared to where I just was in North Carolina,
It's not rural.
It ain't rural. Okay.
so I didn't word that perfectly, but in areas where there's zero transportation, what other peaks in transportation is one of the things that you address?
Yeah.
So food prescription is great as far as it goes. What do you want to build? What do you want to add? What's the missing piece? Who pays for it? How do you get it there?
Yeah, Uber and Lyft. Okay, I'm a union guy, the city taxi people too. What you had to step back and hear what you heard. What you heard was the formula for success. The formula for success here is identifying a problem, and in this case, they identified two of the leading causes of death and disability in the community, putting together a multidisciplinary, multi-sectorial plan and group to do it, right? Health department, health plan, the grocery store, so the business community. That's the secret sauce. And it doesn't matter which program you pick or which problem you solve. If you do it that way, you will be successful. Why do I know that? I mean, we partner with the old Aetna Foundation, Aetna Health Foundation, now with CVS, on a Healthy Communities Prize. And as we looked at the communities that we incentivize to do that, every single one of them showed success because they did exactly that formula. So the issue is, you may not necessarily, it would be great if you could scale this one program up, but the idea is to scale up the concept.
Right.
That's the secret sauce here.
Can I jump in on that? I'm really pleased to hear you say that, and I think a lot of times when I talk about this program, people say, "Oh, this is incredible! You've got the health clinics, and they're connected to the grocer." And what exactly is DC Green's role in this? And at this stage, it's making it happen. I mean, because you have these sectors that are yearning towards each other, and do not have the capacity to actually do the work of collaboration to build a new pipe structure. And at this stage, we're working out the workflow on the clinic side, and we're tapping all of these different partners, and we're proving out the ROI, and we're raising money, and we're advocating for city funding, and all of the things to sort of create a system that actually works. But the goal is, truly, is for us to not have to be in the middle anymore, because you already have a system that's worked, and that requires policy, that requires a lot of multi-sector leaning in. Right. But once you prove it out as a cost saver, I feel like the calculus changes, and that's what we're trying to get to the point where we can do that, even though it's small here.
And we call it, a leadership role there, we have defined as something called being the chief health strategist for that community.
Emily, you're also Beaumont's in a number of communities doing a lot of different kinds of things, not just food. So tell me about one of the things that just makes you glad that you have your job.
Well,
and why it's such good ROI.
Yes, happy to. And I'd also love to bring in the business side of the original question too, which I think is an interesting one for this group to debate. So for Build Health Challenge, it's a funder collaborative. So we have 11 funders, and it's more the philanthropy side of the story, de Beaumont being one of those members. But they're coming together with Dr. Benjamin, what you said about the community-based organization, the hospital and health system, the public health department. That's a no-brainer, as you mentioned. I think what's interesting here, as great as the success is, not all communities have reached that point. And so for Build, we've been able to fund over 37 communities across the country to date. And so we're starting to see patterns and trends, just like these other coalitions are seeing as well. And what's interesting is the sustainability question that I think came up. So how can these groups that are doing great work on the ground in these cross-sector community-driven collaboratives, how can they sustain the work? Because as great as one initiative is, if it's not there the next year after the funding stops from philanthropy or some other stream, it's like if the tree falls in the forest, did anybody hear it? So for the build sites, I think what's interesting to think about is what is that business case and how can business and health come together and meet in the middle to a certain extent? So, it's well documented, right? On average, the stat is US employers lose on average over $1,600 per employee per year just because of lack or decrease in productivity because of health issues. So that's the baseline. So this idea of a business case, for the build sites in particular, it's okay, we understand there's a mutual benefit here. Now, how can we come together to address this? And when you look at other business groups, again, I want to make sure this comes out, Dow Chemical actually looked at who they were insuring, and they're like, it's, our insurance benefits and things like that. 80% were not current employees. They're family members, retirees, pension holders. And so they're like, this case or this idea of business playing a role in community health, they sort of want to take it broader than just one program or one employer or one site. This idea of community health and how business can uniquely play a role with public health working together, I think that's the story and that's the future of business and health.
As you go into a community as a philanthropy with other funders, are the other funders also philanthropies, or do you already from the start, from the get-go, do you have business and philanthropy?
Correct. The original 5 did have one, the advisory board company, and Campbell's Soup has also contributed dollars as well. So over the course of the 3 cohorts that we've run, 15 funders, 2 businesses. So it is a cross-sector initiative. And to the credit of the local communities, right? So we're talking $20 million that philanthropy and those companies have invested over what will be 6 years. But when you look at what the communities have been able to invest, it's twice that. And the hospitals have also matched what Build has put in as well from philanthropy.
And when the businesses are partnering with you, are they partnering with you because they see actual savings accruing to them, or because all businesses want to be seen as good community players?
Right.
And it's a write-off, but it makes people like them.
That's a great, because everybody
I'm not criticizing Campbell's Soup.
No, not at all.
Why are they there? What's the motive?
I think everybody's looking for that story, and it is hard to find, right? So I'll actually lift up some of the awardees. So DC being a great example, but also in other sites like Des Moines, this idea, and we're seeing this across all 37 sites, there is a vested interest from all of those cross-sector collaboratives and the community to look at, for example, reimbursement. So how could insurers actually get in? And I think a great example here was made, and AmeriHealth, I think, is leading the way in DC. They're actually working with our DC Build site on reimbursement as well on pediatric asthma, Ward 7 and 8, also much higher in terms of pediatric asthma. But what has to happen, what we're learning and seeing, and I think it's also been said here, the case has to be made, right? So in one sense, I think the low-hanging fruit, and that's such a bad thing to say because it's not low-hanging, but in the grand scheme of public health.
At least it's fruit.
At least it's fruit. I'm bringing it back to DC Greens. Shout out to you guys. But in the idea of public health, I think when you have these secret sauce type of programs, the sort of on-ramp to sustainability is reimbursement. So follow the money, just follow the money, right? And so this idea of reimbursement with the payers, it's sort of a no-brainer. If I can decrease the number of times a child with pediatric asthma, chronic asthma, is coming into the ER, and I can actually save you money by, for example, going in and remediating a mold issue or a pest issue, that's a no-brainer. That's dollars that you're saving, hundreds of thousands of dollars you're saving in aggregate. So once you have the data, once you have the community will, once you have a framework in place for this and you can prove it, then it becomes a business case model. What I would like to challenge this group, though, and I think Dr. Benjamin, I'd love to hear your thoughts on this too. What I'd like to challenge this group to think is, those connections, housing, for example, is just one area. But when you talk about social determinants of health, you got to think more broadly, not just transportation, not just food insecurity, not just adverse childhood experiences, but also go further upstream. Keep asking yourself, okay, if housing is an issue that I know triggers asthma, what is going on in the house? So there might be family issues, there might be other social justice issues, there might be economic issues, and then ask why again. And you keep going up, and the farther you go up, the harder it gets to make that case. But that's really the sustainable way that we're looking for, and public health is playing that role to look further upstream.
When we as consumers living in a city like Washington, which has a CVS like on every 4 buildings, why do you care about this? And I mean, you're now both you're a wellness health company, you're now an insurer. Which of those several hats under the CVS roof is this a philanthropic thing? Are your clinics, are you doing screening for social determinants in your clinics?
It's all of them,
Will you
actually.
be?
Yeah, it's all of them. If you look at how we're approaching things from an enterprise perspective, where we started, how do we look at it? And it really is what's happening outside of your normal healthcare settings, because you will get a treatment plan or a directive from your physician or from the hospital system that you're associated with. You're going to go back home, back into your community. When you get sick, you're forming new behavioral patterns. And the research shows that when you try to start a new behavioral pattern, you generally fail. So as you look at how you address some of these things, social determinants and otherwise, how do you start embedding access and convenience to core care settings in normal and usual behavioral patterns so that folks don't have to set a new behavioral pattern? And the more you can embed it in existing behavioral patterns, the more likely you're going to have higher compliance, less waste, and better outcomes. So when you look at, for example, the Minute Clinic model that we've developed, all right, we work hand in glove with the physician community, but 50% of our visits are nights and weekends, generally when primary care isn't available.
Because as we've discussed before, no child in America has ever gotten an ear infection in working hours.
That's right, that's right. But also, when you also look at the economics associated with it, a lot of folks, when they take off from work, they don't get paid. So they're not going to go see for care during the 9 to 5 hours. So how do you extend hours to make it available at the same time? We know, for example, that roughly 1/3 of laboratory tests ordered by physicians aren't done. They're never taken. Why? It's a transportation issue. It's the lab is only open 9 to 5 if I take off. So how do you start now embedding these sorts of services where they're available more readily? And then if you look from philanthropic, et cetera, we have now, with U.S. News and World Report, we have a healthiest communities survey. So we survey 3,000 communities across the country each year, going healthiest to least healthy, trying to identify what's going on in those healthier communities, what are they doing, and what teachings, what learnings can you take from them and look to apply into other areas. So we take our philanthropic funding with that research result, and we try to drive results locally.
If I can just jump in again, I mean, one of the things I love about that kind of a model is, again, thinking about a food security overlay there. I mean, the fact that you could put money in people's pockets to be able to then go and buy groceries when they're at a kind of a place that has a pharmacy, it just, not only does it make it convenient for the individual, but if we actually are able to crack open healthcare dollars to put more money in people's pockets, which is getting at a kind of a root cause of poverty, right? It actually secures the market for more small grocers in communities to feel safe carrying fruits and vegetables, which many of them, and we've spoken to many corner stores across Ward 7 and 8. A lot of these grocers would very much like to carry more fruits and vegetables. They're worried the market isn't there. They're perishable. They're working on very thin margins. If we societally know that there is money going into the pockets of people who are experiencing food insecurity and have these diet-related chronic illnesses, specifically to buy fruits and vegetables, it has the potential to have real environmental shift across the built environment. And I think that's the kind of, I think I was saying to you earlier, I call myself a pragmatic utopian. So it's sort of like, that's my utopian vision of this. And if we can keep it inside of the market system, instead of only siphoning off food security dollars for kind of treatment for an individual that is coming only for a food bank or only, I think there's additional ripple effects.
Yeah. I think that point Tom made about how hard it is for people with an hourly wage to take off, because it brings together so many of the issues you're talking about. There's an inequality issue, because those of us who have a different kind of job can take off a couple hours, and if we need to pay for an Uber to make it fast, we can do that, or whatever, the parking. So you have time off from work, which means your job could be threatened, depending on your boss, and you're certainly losing income because you're not working, and then you've got to get to the doctor on 3 buses, because even in places where there's transportation, it's not easily efficient, wonderful, pleasurable, get there in 2 minutes transportation.
Right.
And then you got to get the tests, 2 more buses, and then you get the kid back to the daycare or the mother-in-law or wherever, and then you got to get back to work. Forget it, right? So the more, are you bringing more services into one place? You're doing more lab testing on-site?
Yeah, so we've announced our health hub concept. So by the end of 2021, we'll have roughly 1,500 across the country, and you're going to see much more healthcare related services there. Again, these are complements because, again, roughly 50% of folks who come into Minute clinics don't have a primary care physician. We actually encourage and refer them back to primary care. So last year we made around 4 million referrals back to primary care of patients. So making sure the primary care doctor is that quarterback is essential, but then laying around that the resource to make sure the care plan that's needed is in fact being followed and met. That's the real strategy here. And then we talked earlier before we came on stage, we recognize too there are an awful lot of areas where we are that are essentially food deserts, and we largely the only food source. So we're very focused on what we actually are putting on the shelves, moving to healthier nutrition related items, de-emphasizing some of the less healthy as well. So it's a broad ecosystem, and it's built neighborhood by neighborhood, because neighborhoods are different, but we are flexing the model to meet the local need.
So you're going to, does that mean more fresh produce or frozen or whatever? It's more healthy?
It'll be
It's
neighborhood by neighborhood, but yeah, but
be-
we were talking, and actually we're going to do some research together to see how we actually complement the work that's being done.
Housing, I mean, I said at the very beginning that if you had to make a list of social determinants, everybody in this conversation is going to say housing, and it's probably the most expensive and hardest to do. I said to one of you coming in, my older son is about to get his master's in urban planning, and walking around American cities with him has really changed the way I see things. I'm a total word person, and he is a visual person, and I see buildings, and he sees air rights. So, and he's at NYU, so Sherry Galita's trying to get a hold of him. But, none of you are primarily in the housing space, but all of you are touching on the housing space in some ways. The answer is probably not having hospitals build apartment buildings in general. There are some cases where that has happened, where that is the right solution for the community, but that's probably not the way we solve this. It's not going to be the hospital solving it. And I think I've also learned, and some of you know way more about this than I do, and some of you will have the same realization I've begun to have traveling in the last few months, is there's really two housing crises. There's the one that we see on our streets, which are very much, many of them are chronically mentally ill, right? There's a sort of a less visible one of working poor families who cannot afford a place to live, including in rural America. It's not just Silicon Valley. And maybe we're creating the next generation of chronically ill because of what's happening to these kids, who changing schools and sleeping on floors, and it's not as visible, and I think we don't understand that there's really sort of 2 separate problems. What is the role of the healthcare system? When and how do we spend a healthcare dollar on what could really be? I don't know what the cost of fixing housing in America is, but it's higher than I can count.
They don't have to do that. I mean, it would be
so
nice
how do we
they don't have
partner?
to do
How do
that.
we partner?
They've got lobbyists that spend a lot of time lobbying for reimbursement funding. Spend 1/10
Who's they?
of that,
The hospital?
the hospital,
Okay.
or the health entity. Spend 1/10 of their healthcare lobbying dollar to lobby on policies like zoning, affordable housing.
Yep.
They're in many communities, they're the biggest employer in town, which means they're the big dog. They can decide whether or not there's housing in our community or not. And then if they want to leverage that, it's fine. They want to get into the housing business and buy a few houses, that's fine. It's a real estate business. They got to know what they're doing, but they could do that. But, there's a whole spectrum of things they can do, from, simply getting people the social services that they need, to spending their enormous, enormous clout, 1/10 of it, to make sure that everyone has a house. By the way, the reason, the medical solution to homelessness is a house. Okay, and we know that having a home, a place to go to, totally stabilizes your care. It is, you're right, it's a major factor in the ability to deliver effective health services. And of course, a safe, affordable house is important. But the point is that—
It has a huge impact on education.
Yeah,
too.
far too often, we run to what we know, which is, writing a consult, or if I can't pay for it, I can't influence it. And yet, the clout and the ability of these enormous systems to do that. Now, are there models that have done it? I mean, 40 years ago, the old Greater Southeast Community Hospital, I think is Unity now, in Ward 8 in DC, actually did that. They saw that infant mortality was a big issue in the community, and they started engaging aggressively around urban renewal in the community right around that hospital as just a matter of economic survival. And they focus a lot on substance abusing pregnant women because that was a challenge at the time.
As it is now.
As it is now. And of course, HIV and AIDS. And working with clinics like Whitman Walker Clinic here in DC, they were able to begin the process of turning around. Then, of course, the CEO left, the board chair left, and it stopped. But we have models like that all over the country.
And are those models seen as, for the rest of you, as within reach, or is it seen as too big a problem for the healthcare sector to tackle? I mean, is it seen, do you say, well, that's a HUD problem, we're never going to get HHS to work with HUD or Medicaid or what? I mean, is it, you can sort of see, like with Medicaid managed care, you can see how you can pay an Uber fare out of it. It's harder to see how you build 20 apartments.
When I was a resident, 80% of kids who had leukemia died. They don't die at all now. They rarely die. We focus on the problem.
So have we changed how we see it?
We need to say, okay, we want housing to be a problem. We're going to bring together a group of people. I am the health leader in that community. I'm going to sit down and bring people together, and then we're going to go sit on in the economic development's office and talk to them, and then go talk to the mayor or the governor, and we're going to solve the problem. And we're going to help them spend their money, not my money, but their money, but in a more effective way. And then we will help with that process.
Bringing the moral authority, I think, of the healthcare system to those, it's a huge thing when the physicians show up around an issue and make it clear that it's hurting everyone's bottom line. I mean, even if you have to speak in those terms because whoever you're trying to move isn't moved. But I mean, like the Root Cause Coalition, I think, has done incredible work. And for those of you who aren't aware of it, I mean, really, that's come out of Promedica, and it's a real national movement of healthcare systems that are trying to address root causes, and just being able to have that, the hospital systems and the payers show up and say these are issues that matter goes a hugely long way, I think.
So Emily and Ashley, are there examples of communities that you've been in where this process is beginning, and not just in a, we're going to do this and say we did it, but in a way that's catalyzing real change in terms of understanding the role of housing in health and well-being?
So just an example I would share from Promedica, since Lauren brought them up. So we're fortunate to partner with them in all of the work that they're doing in Toledo. We started by taking a broad look at social determinant risk across the entire 28 county service area that they're supporting, and look specifically for segments of the communities and populations that they're serving for which excess social risk, particularly around housing instability, but other domains as well, is correlated with utilization and cost or poor outcomes in a way that we could quantify for them internally first, right? So that creates the compelling business case for their leadership about why this is something they should be talking about at the board and executive level. The second thing is it allows them to think more strategically about the programs and interventions that they've already invested in today. So things that they were running on the ground but had no idea of knowing if they were reaching the highest risk population. So we can think about precision deployment of those existing interventions in a way that is going to have a bigger impact on the community and make better use of those dollars that they're already spending first. The second strategy is then to think about who are the partners in the community that are already doing the work that could be supported by that precision deployment that they could partner with. So not new programs or interventions necessarily stood up by Promedica, but new partnerships where they can bring a shared view of risk to the table as a starting point for conversations with those agencies about how they can partner more effectively together. And then the third and final step, only if there's a gap in the need that can't be met by those first two strategies is to think about net new investments in programs. And that is something that does make sense if you have the business case, if you've already determined that it can't be met by an existing internal partnership or program, and there aren't external partners in the community that are already doing this work. So that's how we've approached it with them.
Joanne, I'll just add two points, because I agree with my colleagues here. I mean, for the Build Health Challenge sites, I think an interesting thing, some examples in Cleveland, in Charlotte, in Greensboro, microphone. Cleveland, Ohio, in Charlotte, and in Greensboro, North Carolina are some good examples if you're looking for some in the housing issue area. The only thing I'll add, though, is I think it's also, I don't want to over-compartmentalize or overgeneralize housing, right? Because I think what we've seen with some of the build sites, and key here is the community-led element in this. I think that's something that I think we all agree on, but just want to articulate out loud. The community for any program, any project, that's the core of the secret sauce, right? So let's not forget that. But when you start peeling back the layers of the onion on housing, right? Some of the sites that we've been fortunate to work with, you know, they're also tackling things like rental registries, housing inspections. We did a quick survey of how many just simply housing inspectors there were per rental units in some of the communities we were working in. So even if you were to provide housing or low-income housing or any of those on-ramps, you know, are there enough people or processes in place to help maintain and make sure that the health and safety and well-being of those residents is maintained in, again, a sustainable way? So just lots of onions, layers of the onions to peel back as you all consider this.
I just want to add to that. So two things. First off, the concept of the public-private partnership is real in this area. There are proof points, though, that I think need to be developed. And we've done one in just outside of Philadelphia with the Medicaid program there, where we actually built an apartment building that's used for folks, you know, suffering through some mental health issues, et cetera. But that's the stability that allows it. And it's transitional, but it's also can be, depending on how they're doing, can be also, you know, more stable in that way. And it starts to generate data, where you start seeing results coming from it and the influence of that, you know, stability, how it's impacted the care. That then leads to a proposition more broadly that you can take to others to get a broader public-private partnership together. The other is, I don't want to lose sight of, as you look at a lot of the community health groups, they now are recognizing the role that lawyers can play in Section 8 housing and other things.
Yeah, we
so
were,
they're actually,
at an event together in Philadelphia,
yeah,
and I did not, it's really interesting.
It's fascinating how, you know, just simply having that skill set available at the community level, because the funding's there, the housing's there, but folks don't know how to go about getting it. And just creating that pathway opens so many doors.
So another social determinant of health is getting not just a lawyer, but the right kind of lawyer. It was really quite interesting what's going on, how integrated that is become in Philadelphia. I'm not so aware of other communities where. How long is this transitional housing? When did you do this? When did you start?
It started, I think, about a year ago, but it's built. So we're working with the state program, and it's ongoing.
And what do we? Well, it's only a year, but do we know from other programs like it? It's mentally ill homeless people have a lot of challenges in life. Do we know how long you were keeping them stable?
Well, it's not just that, it's spousal abuse situations, et cetera, but you give that stability, the transition back to community, to steady jobs, et cetera.
Is there social workers on site?
Yeah, you're seeing real data sets coming out of it now that it makes a huge difference. So to what the panel was talking about, you develop these value propositions, then you really create a model by which the public and the private can get behind it and build it more broadly.
And is this something that is sort of a healthcare dollars, you know, hospital system, healthcare system, finding a community partner, or is Wall Street about to realize, social determinants of health, good business? I mean, where are we heading with this in terms of funding? And I know that 2020 and whatever our next healthcare debate, I'm trying to figure out, like I need a sleep bank to start getting ready now. Assuming we're more or less on a trajectory that now. I mean, what happens next? Who starts funding this? Who makes it not an apartment building, but blocks of apartment buildings? How does it happen? Does it change to a business? And was that good or bad?
Well, we know that hospitals have a requirement to do a community benefit, a community needs assessment.
We also know that sometimes it means running a...
Yeah, we know it's done, and hopefully the IRS will tighten up on that and begin to actually link the assessment to what they actually do. But assuming that happens, then there's a whole range of issues here, because once you start moving in that direction, that becomes real money on the table that can be moved around to provide a variety of services. And I mean, the ultimate goal is for us to decrease utilization of inpatient facilities and do much more outpatient. And the technology and the skills and the automation we have and the skill set of the providers is allowing us to do more and more and more of that, particularly in an aging society. So this is a model that is just not for the acute care system today, but it could easily be a model for those of us who are about to get real old with our fixed knees and our hips, and hopefully we'll fix the Alzheimer's part too, but we'll be living in the community, and we need to make sure that those community issues are addressed because, you know, as the baby boomers age, the challenges that these folks are having right now, those models could be very easily adapted for a community that people are living longer.
So I'm only coming from the food space, obviously. I think
But people need a place to cook, and they
well,
need a place to refrigerate their food, and they need...
No, absolutely. There's many nested things. I think what I see as important right now is getting food at least out of the sort of charity bucket of investment for the healthcare system and really moving it into that core business case. And I think what you end up seeing, or what I'm starting to see, is that you've got a lot of nonprofits that have been invested for a very long time in it. There's the folks that are doing medically tailored home delivered meals. There's an amazing Food as Medicine coalition across the country with a lot of, there's food banks that are investing in food pharmacies. And it has been the sort of nonprofit sector that's trying to push policy and trying to push this sort of deeper integration of food as medicine into the payer system. And now what's happening is you have a lot of for-profit businesses that are sort of saying, this is great. We want, I do prepared foods really well, and we can get into that space. And I think that's a good thing. I think that is a sign that, we're on the cusp of actually making this profitable to everyone. And I think in order to actually scale these kinds of solutions, you need to have, for-profit businesses coming in as well. So, I mean, I think that was a piece of your question, like, is it just the nonprofit sector? I think it is a sign of success if we have, multiple solutions coming from different areas. And honestly, I'm in a lot of conversations about, creating clinical community connections. That's the line. We need to, this referral system, and there's the DC Pact, and we're trying to figure out how do we get, we are identifying these social determinants, how do we get them out to the social services? And as a social service provider, many of us are like, hey, we can't afford to actually support all of the referrals. So unless we're actually simultaneously thinking about how to, bake that funding and share that risk with the folks that are actually, saving off of it, that's really only a partial solution, and it will fail.
One of the changes as the social determinants conversation has evolved over the past few years, I think people used to, and I don't mean this in a negative way, I mean, it's a learning process, is that somebody in need, and usually with multiple needs, because people don't have, a homeless person has multiple needs. A chronically ill person has multiple needs. They come into whatever their point of entry is, and they get a piece of paper with a phone number, and good luck, right? And it's now moving toward the screening and giving a phone number is not the solution. That the healthcare system, the community organizations, the volunteer organizations have to be activated, have to talk to each other, have to follow through, have to have accountability, transparency, all that. And I don't mean this at all critical. I mean, talk a little bit about how you are seeing that change, and then how that's also expensive. I mean, that coordination is not all just, I feel like talking to you today. I mean, how do you build those systems and create a network where the networker is responsible for the person in need? If giving somebody a phone number on a piece of paper was going to solve their problems, they wouldn't have the problems in the first place, right? So what's the extra complexity, financial, business case for saying it's on us, and it's on us together? So talk about a little bit of that, whoever wants to jump in.
Well, it's about accountability. So at least for health systems, again, going back to the community health needs assessment, every community, we have the data. The data is out there. The health department has it, either the local, city, state, or local has the data. They've done the assessments and creating the benchmarks and then holding themselves accountable for those benchmarks. I mean, at the end of the day, this is not about how many patients you saw. I mean, that's a nice number. You know, it is about, from a business perspective, how much revenue you produced and how little you actually had to spend to get that revenue. But if you're not in the health business, what are you doing? You know, many years ago, we had this huge fight with the automobile industry over the fact about whether cars should be built safely or not. And the retort was, well, why would anyone buy a safe car? That's not why people buy our cars. They buy them for other reasons. Well, they're now obviously actively marketing their cars on its safety. We changed that paradigm. We need to change the paradigm around health systems, that if they're not producing health, then why should they be in the business? Why should they be a nonprofit? Why should they get the tax benefit of deferral from that? I mean, if you're not producing health, why are you doing this?
I'm so sorry, just very quickly on the
Yeah, go
car,
ahead.
because the analogy, I mean, I was speaking to someone yesterday who was involved with lobbying around that, and what she said is it's a perfect analogy because the car insurers actually got together and started testing, doing their own market testing and sort of feeding
And
that
pushing it.
back. Exactly, and I mean, I think that is a perfect analogy to what really needs to be happening here. The insurers who have that vested interest in building a safe environment, a safe system, you know, environment, really need to be leading and then forcing the market in that direction.
I'd just add, I think at a very high level, folks realize that the current pace of spending in healthcare is unsustainable. So you have 18% of our GDP right now, projected to grow to 21% in 7 years. Every 1% is another $250 billion that won't be available for education, infrastructure, and other key investments. So what does that force smart people to do? You start looking at what are the causes of the cost increases. And you start looking, okay, non-adherence to medicines costs us $300 billion a year. Well, why is there non-adherence? You start looking at behavioral, other issues, and you start breaking it down to root cause things. Same on hospital readmissions, right? And then we learn, as we get through some of these things, as you boil it down, that there are 3 or 4 things that you can really focus on at a local level that can have a huge impact in that cost curve at a national level. So we were talking backstage about how many medicines do we all take every day that it says take with food? Well, if you don't have food, that medicine likely is not going to be working because the metabolic aspect of it requires some form of food to be taken with it so it truly can work. We look at hospital readmissions. Why does it happen? And you can get to things like what's happening in the home. You have a knee replacement, and as you're leaving the hospital, they give you the list of all the things you need at home to recover. Well, why don't we give you that list before you go in, so that things are waiting for you when you get home and you're not, you know, hobbling around, falling down, trying to get all this stuff. It's just taking a little bit of knowledge and personal experience and then pushing it forward to ways that can make a difference. And these are not major changes. These are kind of almost behavioral level things that can make a huge difference.
Before we turn it to audience questions, we are in the midst of, you know, value is sort of, you know, in the eye of the beholder, but we are in the midst of this transition to a value-based medical system. Medicare Advantage rules now allow more spending on social determinants. Some of the Medicaid managed care, it varies, but some of the Medicaid managed care plans are doing more on this than others. They have so the legal authority to do that they didn't have, they had less of in traditional Medicaid. Is this value conversation, and every time I write a story about it, you know, I get a lot of angry emails saying, yeah, value. But also sustainability. Every time I say it's not sustainable, there's some grumpy economist that says, well, we've been sustaining it for a long time. But I mean, is the shift in payment and MIPS and all the new acronyms, is there an opening that the social determinants world should be seizing hold of, and is it meaningful, and can this be not just a different way of paying doctors in Medicare, but is this a vehicle for changing how we think about smart healthcare spending, or is it just, you know, another 20 years arguing about what's value?
Well, it's not sustainable, the cost, and it's not just, you know, we could go to, you know, 25% of the gross domestic product. I don't know if that's the issue. The issue is how much I got to pay out of my pocket for it. That's the driver. You know, how much Uncle Joe and Auntie Sue got to pay for something. and we are affording unsustainability there. There's no question about that. People are not able to afford it out of pocket. And so all this cost shifting that we've done is a problem. So I think that's the opportunity, that there's cost. And yeah, value is in the eye of the beholder till they get sick. And one of the things that having practiced medicine, I've always recognized that you're opposed to what I want to do until you get sick. And I'm always ready to help you when you get sick. I try to convince you, to address it beforehand, but I have seen so many people change their tune when they or a family member or someone they care about, or even the neighbor that, that lives next door that they hadn't thought much about, but now something happens to them. Suddenly they become supporters of healthcare and they're supporters of value. So the question is, how do we accelerate that learning curve? And I think being more forthright about what these outcomes are, talking about these outcomes, is going to be very, very important to us. Saying, we provided housing to folks and we got them in housing, but we need to take the story to the next step and say, okay, here's the value to the community, not just the value to the individual, but here's the value to the community for doing that, so that it becomes a shared value across the society.
Somewhere across town, Senator Grassley is happy to hear you talking about one of his hobby horses, right?
Yes, it is.
That tax break, you need to do something with it, right?
I was actually in Iowa with him and we talked about that.
What the value and the Venn diagram between value-based care and social determinants.
Yeah, so I would say that those of us who have been in the social determinant space for a while are thrilled to see the ongoing shift of risk to organizations that have a closer connection to the communities and populations that they're now at risk for, right? Because they're a closer effector arm for some of these interventions, right? So the growth in managed Medicaid, the growth in Medicare Advantage, the value-based models that have emerged on the commercial side, all of that helps create incentives for healthcare systems who are often anchor institutions in their community to get engaged in this work. Whether that's as a funder, whether that's as a direct provider of the services, doesn't really matter. It matters that their executive teams are engaged in this conversation and partnering with folks on the ground to advance the effort. We think that there is now a compelling business case in most communities. I mean, it does vary a little bit market by market and state by state, but it's growing every day to incentivize those types of conversations. And from our perspective, that's a great thing.
And that is literally what we did. As soon as there was a shift to value-based care, we went to AmeriHealth and said, we've been running this program at farmers markets and we've seen individual health metric changes, but what we've really seen is a 60% increase in well patient visits because people are getting food. What do you need fixed?
Right.
And that's where it started.
There's probably a mic. Is there somebody with a mic in this room? Okay, if you would like to have a question, raise your hand right here. Woman in that row. Can you identify yourself, and can you please not give a speech, because I am much more ruthless than I look.
Thank you so much. My name is Katherine Connelly. I'm a dual MPH MBA student at Johns Hopkins, and so this really speaks to my interest. But my question sort of reflects on the shape of this panel. We see really great involvement from nonprofits, from the health sector, but we only see one Fortune 500 company. How do we convince other large companies to really get involved in the business side of social determinants of health, particularly when you spoke about using political clout? When we look at a company like Amazon and their new headquarters and the potential clout they could have in terms of housing or other social determinants of health. So how do we engage those non-traditional health actors that are really the strong businesses to take this on?
Who wants to take it?
I'll just quickly, I'm actually leaving from here to fly out to Google because we're launching a food as medicine accelerator with Google. So I do think that there are a number of players that are trying to figure out exactly where they are best situated. I know Lyft also, you mentioned, is very interested in not only grocery access, but I think what I'm seeing, at least, is a lot of these Fortune 500 companies that are saying, how do we use our core competencies to support this effort? Because there's a shift in corporate social responsibility now too, right? And so they're trying to actually be a part of the change and not merely write a check for the change, which, you know, has pluses and minuses. But I think we're in a moment where they're cogitating, and I think are showing up more and more. That's my read. But I'm an eternal optimist.
Well,
so.
I'll add to it. I think
And
they're-
a utopian pragmatist.
I am.
A lot of
I think they're doing more than cogitating, because in the same way the federal government, the state governments are looking at where their expense lines are going, the benefit managers in each of these companies are seeing the same cost pressures. So they're looking for solutions that make sense. And as you bring the data, as you show the impact that you can do at a local level with socially determined related solutions, they do make a real impact. And they recognize, like Dow recognized, that yes, you're ensuring obviously your employees, your colleagues, but you're ensuring 1x, 2x beyond that in terms of an extended family and extended community. So you have to think beyond the four walls of your employment location and look more broadly into the community in terms of how you do it. So I do think there's a lot of movement. You may not be seeing it being reported, but a lot of stuff is happening at the benefit level in these companies.
Emily.
Thank you. And may I commend you on your MPH MBA pursuit, because you are a unicorn in the public health space, so that's good. The future rests with you. So just in response to that, because I think it's a great question that gets at the heart of why we're all here, right? From the work we've been doing, from the many folks we've been very fortunate to speak with from both the public health and the business side to try to get at this, what we're seeing is, and I'm just going to lay it out there, right? And I don't want to overgeneralize, but literally after talking with 100 corporate executives as well as public health folks, what we learned from this one study was public health and business don't really mix. It's like oil and vinegar from a traditional sense, right? I don't think I'm saying anything that surprises folks. Business folks tended to say, look, public health, especially governmental public health, you tend to work slower than we want. You tend to have a lot of bureaucracy or hoops to jump through. You tend to have other challenges that, and your layer of expertise, your evidence-based nature may sometimes not gel well with what a business, and vice versa, right? From business's standpoint, they're trying things maybe in an entrepreneurial manner that may not suit. And you're like, we know what works, why are you trying this method? So I think incumbent upon your question is this idea that honestly they need to come together, because it's going to take both sides of the coin in order to address these long-term issues. I just want to note, it took decades for us to get to this point in a number of issues, whether it be redlining, whether it be social justice issues, whether it be food deserts. These things took decades to occur. So in this conversation about social determinants of health, I think we need to recognize this is a long-term game, but there's lots of short-term wins to be had. And I think that's what we're trying to showcase here with the folks in this room. How can we keep building off of those short-term wins? And I think that's what's going to drive this forward to become more of that national conversation and a norm rather than these one-off success stories. So one quick addition on that, though. One of the things that we found that's been really successful in getting employers engaged in that conversation is looking at the metrics that matter to them. So we naturally gravitate towards their healthcare spend, right? What they're spending per year to ensure their employees and their dependents. But what we've realized in some of the analysis that we've done for employers is that other metrics are impacted by social determinant risk. So absenteeism, presenteeism, turnover rates, promotion rates. There is a correlation between social determinant risk and those metrics for several of the employers that we've worked with so far that is part of a broader strategy that they might have that helps elevate social determinants out of the benefit design kind of HR space and into something that speaks to their broader strategy, and that can be really effective.
We have probably one more question, and we need to keep the answers shorter this time.
Sorry.
Okay, so I'm Michael Golikov, Senior Vice President at Caritas Caritas, corporate, not DC.
Thank you.
And thank you for all the PR. I appreciate that.
I do my best.
I hope there's press in the room. But I wanted to make one comment. By the way, business and public health, oil and vinegar do mix. You need an emulsifier,
Oh,
and
they
the
do.
emulsifier
Yes.
could be data.
Yes,
So-
yes. I don't mean to say it doesn't work.
I also
Yeah.
wanted to ask about what you guys think about Project Home and some of the data and stuff that's come out of there. And also one other quick element to that. When you think of, I usually don't hear it in the context of social determinants, but I think we need to add it around people with chronic condition, and that is caregiver and social support, and whether what your thoughts are about caregiver support as a social determinant that might also be one of the things that can drive longer-term benefits.
Does one person want to take that? Because we're going to.
Well, I'll hit the caregiver. It's very clear the data is there. So the more connected you are, whether it's with a family member or someone else, a neighbor, as you're working through chronic conditions, your path back to better health is going to be an awful lot better. So that has to be a component of it. And it's largely information flow, but also the touch point to making sure you're doing what you should be doing and a reinforcement point. So there are a lot of ways to make that happen, but that person-to-person really is the most impactful.
And we need to so I think next year we could have an entire panel on the ways that you could use food to create connection and address isolation and other things. So it was a great conversation. I think everybody will be around. They'll be outside, but you can get them. Thank you for attending, and we'll see you later in the day.